Hello everyone. Today we are going to discuss about vesico-ureteric reflux. First, let us understand what is vesico-ureteric reflux. Normally, urine flows from the kidneys through the ureters into the bladder, and then it is expelled out through the urethra to the environment. In vesico-ureteric reflux, instead of flowing in the antegrade direction, the urine flows back into the kidney due to the problem in the vesico-ureteric junction. This condition is called vesico-ureteric reflux. It causes dilatation of the upper urinary tract, may lead to infection, and ultimately may lead to damage to the kidneys. Hence, it is a very important condition which we have to diagnose as early as possible in the neonate, in the infant and childhood to prevent and minimize the damage to the kidneys and prevent the infection. Now, how do we recognize vesico-ureteric reflux? Before delivery, it can be recognized in the anomaly scan. We can see the dilatation of the upper urinary tract in the sonography. If it is involving the ureter on one side or both sides, then it is suggestive of megaureter, and possibility of vesico-ureteric reflux is predominant in that. After the birth, the child is followed accordingly. The main presentation in the childhood, they include painful micturition, frequent micturition, dribbling of the urine, recurrent fever, discomfort, fever associated with chills and rigors, failure to thrive, and often vomiting. Now, these are of two types. The vesico-ureteric reflux, basically it is of two types, primary and secondary. In the primary, the vesico-ureteric junction, which is competent in the normal infants, is developmentally defective, so that it does not prevent the reflux of the urine upward from the bladder into the ureter. This is because the vesico-ureteric junction, which acts as a valve, that becomes functionless or its function decreases. Rest of the bladder and the urinary tract is normal in primary VUR. Coming to the secondary VUR, the vesico-ureteric junction itself is normal, but the problem lies either in the bladder. The bladder may be either infected, which is called cystitis. It may be neurogenic bladder. There may be anatomical obstruction within the bladder, or moving below, there may be bladder outlet obstruction, either detrusor external sphincter dyssynergia, non-neurogenic bladder. Because of the chronic constipation, post-ureteral valve, ureteral structure, anti-ureteral valve, or meatal stenosis, these are some of the causes of the bladder outlet obstruction. This increases the bladder pressure in the bladder, and consequently, the vesico-ureteric junction opens secondarily. So, in secondary VUR, we have to treat the primary cause. Now, how to diagnose it and how to investigate it? After the symptomatology, the main investigation is required is an ultrasound of the KUB, which suggests the dilatation of the urinary tract on one side or both sides. After that, if there is dilatation of the ureter, then we go for VCUG, which is voiding cystourethrogram. It is a contrast X-ray in which the dye is injected through the urethra into the bladder, and if there is any anomaly above and below, the dye under fluoroscopic guidance and tells that where the pathology lies, whether it is primary, whether it is secondary, and also it tells us about the grading of the VUR. Now, coming to the grading of the VUR, these are of 5 types from number 1 to 5. VUR grade 1 is mildest form, in which there is no dilatation, simple VUR into the ureter that flows back into the bladder. There is no damage to the kidneys. Grade 2 is also milder. Grade 3, the urine reaches up to the kidneys and there is some dilatation of the urinary tract. Grade 4 and 5, there is gross dilatation of the ureter. There may be tortuosity of the ureter. There is dilatation of the pelvic alicizal system, and associated with that is the thinning of the renal parenchyma, which leads to damage to the kidneys. And if there is superimposed UTI or urinary tract infection, the damage becomes more exaggerated. Hence, we have to control the infection also, and we have to control the reflux also. Coming to the treatment modalities, the early grades, grade 1 and grade 2, they may be observed. If the urine is not infected, we have to keep the urine sterile, and we have to teach the toilet training. Patient is followed closely, and most of them, they subside spontaneously without any intervention. After grade 3, grade 4 and grade 5, they may need intervention. First of all, we have to keep the urine sterile by local hygiene, by antibiotic cover, and urine checkup, which includes the routine urine and culture sensitivity. Coming to the treatment modalities on the surgical aspect, these include endoscopic treatment, laparoscopic treatment, vesicoscopic treatment, and also, of course, lastly, the open surgical correction of the vesico-ureteric reflux. So these are some of the modalities. If your child presents with any of the symptoms like difficulty in maturation, there is recurrent fever associated with foul smelling urine, there is vomiting, which is not related to GIT, which is not related to respiratory tract infection, then we have to go to see any infection in the urinary tract or any anomaly in the urinary tract. Hence, we have to consult the pediatric urologist, whoever is nearby. We are dealing with such cases, and accordingly to each child grade and severity, we treat the patient. So please feel free to contact us. Thank you so much.